Hello everyone, hope you're all doing well. In the next 5 to 10 minutes, we are going to discuss a high yield MRCOG Part 3 recall station. This is a woman around 60 years of age who presents with postmenopausal bleeding. She has already been to the GP and the GP has arranged an ultrasound scan. And now the scan shows the endometrial thickness of 7 millimeters and you have got 2 cross 2 centimeter endometrial polyp. She's now in the gynae clinic and your task is to discuss the results, explain what they could mean to her and outline the next steps, okay? So now what makes this station tricky is, and why it is a recall, is that it's not just a postmenopausal bleeding and a polyp station, yeah? The background history is the real test. Unless you ask the right questions, you won't unlock the station. She has got a past history of stage 2 breast cancer, treated with left mastectomy and chemotherapy. It was a hormone receptor positive cancer. She has taken tamoxifen for about 7 years and the last dose was about 3 years ago. So she also has a family history of ovarian cancer in her aunt. So, and in addition to that, she's taking herbals or over-the-counter remedies for her hot flashes and menopausal symptoms. So the key learning point is ask sensibly and routinely, okay? So you should be telling her that these are the questions we ask routinely for all women, and then inquire about a personal and a family history of cancers to understand the risk factors, okay? So you can ask it in a routine blanket way that have you ever had cancer such as breast, womb or ovarian cancer? Any family history of breast, ovarian, womb or bowel cancers? Has anyone had genetic testing or whether herself has done any genetic testing? If she reveals a breast cancer and a family history of ovarian or a breast cancer, you should widen your lens and ask about her pregnancies and deliveries. Whether she has got daughters, yeah? Then you need to do the safety netting over there itself, that genetic counseling and gene testing is something we need to tell her, because if she comes positive, then daughters may also need counseling, screening and surveillance, okay? That becomes important family safety netting over there. Most important information gathering you should not be missing in this task is symptoms that suggest ovarian or a sinister pathology. Ask about pain, abdominal bloating, because this could be an ovarian tumors. Because some ovarian tumors, especially hormone-producing tumors like granulosa cell tumors, can increase the estrogen levels, thicken the endometrium and cause bleeding. And ask about any issues with her bowel habits or water works if it is relevant. And as far as the cervical pathology exclusion is concerned, even if the ultrasound shows a polyp, you must still rule out a cervical causes in there. Ask about foul-smelling vaginal discharge, any unusual discharge, post-coital bleeding if she is sexually active, whether she is up to date with her cervical smears or not, okay? Third most important thing is medication and hormone exposure. Any hormone replacement therapy, any tamoxifen, current or past use, duration, when was it stopped, any herbals, over-the-counter medications, and the menopausal remedies if she is taking. Because you don't know they contain estrogen-like components, so it's important to understand that. So as far as the personal and family history of concerns, which you have already asked, right? Whether any personal history of cancers, any family history of breast or ovarian or womb or bowel cancers, and anyone underwent a gene testing. So these are the questions which are important in here. Has anyone had genetic testing? If she reveals a breast cancer, yes, ask about any daughters, pregnancies, deliveries, and then you do the safety netting in here. Risk factors and social context is concerned, BMI becomes important because being overweight increases risk of endometrial cancers, and smoking history becomes important. Diabetes and hypertension if relevant, because it could be a metabolic syndrome altogether. And lastly, support at home also matters, because in this station she was living alone, husband passed away, so you should explore the support, involve the GP, community support if needed, okay? In the examination, yes, you're going to do it in the presence of a chaperone, and most importantly, check her blood pressure. If she's obese, tell to mention that you would do it with appropriate cuff size, and do an internal examination as well to look at the neck of the womb, okay? And so those are the most important things which you need to worry about in the information gathering. To how to explain the scan in a more patient-friendly language, avoiding medical jargons. Of course, this is not going to be like a Breaking Bad news, but you need to be very clear and structured in your explanation. So you can say something like, let me draw this and show this is your womb and this is the inner lining of the womb, and the scan shows a small growth arising from the lining, what we call a polyp. Okay, and the scan also shows the lining is bit thicker than we would expect after menopause. After menopause it is usually less than 4 millimeters, but yours measures around 7 millimeter. If she asks why is it thickened, I mean what is the reason behind it, you can answer with a balanced possibilities in here. So what are the usual causes of postmenopausal bleeding? Explain in simple categories. Okay, it could be the thinning and fragility of the tissues after menopause. Atrophy, what we call, is common, but it is less likely here because her lining is thickened. It could be an atrophic vaginitis, that could be possible, or innocent overgrowth like polyp, what she is having in here, or inner lining of the cells are growing rapidly, more than the usual, what we call endometrial hyperplasia with or without atypia. Cancer of the lining or the cervix is also a possibility we must exclude. Ovarian tumors producing hormones that can thicken the lining. Medications or exposures like tamoxifen or estrogen like herbals. Okay, if she asks directly, is it a cancer, or if she becomes very anxious about the same, you can say cancer is one of the possibilities. So 1 out of 10 women can have the cancer, but it is also important to tell her that this is not the most common cause. Overall, about 9 out of 10 women with postmenopausal bleeding do not have cancer. However, we take it seriously because the only way to be sure is to test the inner lining of the womb. Yeah. So we need to do certain investigations in here to know what we are dealing with. You need to offer her hysteroscopy with a biopsy with a removal of the polypectomy. So explain her that a thin camera is passed through the cervix to look inside the womb, and we are gonna examine the inner lining of the womb. We take the targeted biopsies, remove the womb, send everything to the lab. Then only we can confirm what it is. Yeah. So the options mainly available for her is outpatient procedure she can choose to have, or daycare procedure under general anesthesia if she prefers, if that is relevant for her. So try to tell her certain risks as well. So tell her that these are the risks I want you to be aware of. This is not to scare you. So you can develop pain or cramps, bleeding, infection, a small risk of injury to the womb. And if she undergoes this procedure under general anesthesia, anesthesia related risks will be there, that will be discussed by anesthetist. If she asks what will the treatment look like, yeah, so you need to tell her that clearly that if it turns out to be an innocent polyp, no further treatment is required usually, just the reassurance. If it is hyperplasia, the cells are dividing rapidly without looking abnormal, I mean to say without atypia, then we can discuss with her about the Mirena coil. So the hormone coil which we can place inside the womb, that can take care of this problem. But in her case, because of past hormone receptor positive breast cancer, you must say we would discuss these hormone based options with your breast cancer team to ensure it is safe for you. Okay, you cannot advise her a Mirena coil or any hormone pills just like that without discussing this with a cancer specialist. If it turns out to be an atypical hyperplasia or a cancer, then urgent referral to gynae onco MDT, because we need to stage the cancer. If it turns out to be atypical endometrial hyperplasia, the standard treatment would be a keyhole surgery to remove her womb, both the tubes and the ovaries, and depending upon what we find on the final histology, additional treatments in the form of radiotherapy or chemotherapy may be needed. But also tell her that if we detect any womb cancer early, the outcomes are generally good. And at the same time, it's important to tell her that this is too much to discuss at this point of time. So we are gonna do the hysteroscopy, the biopsy and the polypectomy and examine it under microscope, get an opinion from the tissue experts, and then we'll be in a better position to explain what her treatment would look like. So once we remove her womb, ovaries and tubes, if it turns out to be an atypical endometrial hyperplasia or a cancer, whatever the menopausal symptom she is having, that might get worsened. So if she's taking herbals for her hot flashes, advise her to stop all the over-the-counter or herbal remedies for now, because we can't be sure what hormones they contain. That's the most important patient safety point. And be clear, given her history of hormone-positive breast cancer, HRT is usually not recommended. We can support her symptoms with the non-hormonal options and lifestyle measures. That is also a most important patient safety point you need to tell her. And not to forget about the genetic counseling. If you have not addressed it before, do the family safety netting as well. Because she has a personal breast cancer and a family history of ovarian cancer, offer referral to the genetic counselor and do the gene testing. And if the gene testing comes positive, discuss implications. Her daughters may also be offered counseling, testing, and surveillance. So frame it as a protection, not to make them become panic about the same. And since she lives alone, social support is also something you need to highlight upon. So acknowledge and offer that, you know, we will inform the GP, the health visitor, the social worker will be a part of her care, and she will not be left alone. Okay, so that is something is extremely important in here. Communication with the colleagues will be marked in here is at this point of time, the consultant and the anesthetist is someone we need to communicate with. But if it turns out to be an atypical endometrial hyperplasia or a cancer, then the entire multidisciplinary team will come into the picture there. You would involve the consultant gynecologist, the cancer surgeon, the cancer nurse, the cancer specialist, and her breast cancer team as well. Anesthetist, the tissue experts, the scan doctors will be a part of her care. So that's how you would score in a communication with colleagues. And as far as the communication with the patient is concerned, the way you explain her about the polyp, thickened endometrium, the possibility of the causes for the postmenopausal bleeding, and what is the chance of that this could be a cancer, and reassuring her that 9 out of 10 women will not have the cancer, but the only way to understand is to do further tests. So these things will come under communication with a patient. Most important patient safety point here are inquiring about smoking, inquiring about BMI, and addressing those two if they are something, the BMI is high or she's a smoker, and if she's on herbals, then that needs to be stopped right away, which is also a most important patient safety point. And also doing the safety netting, that referring her to the genetic counselor, getting the gene testing, and implications on the daughter. So those are all the important patient safety points which you guys have to take care of. And as far as information gathering is concerned, which I have already told, most important questions to rule out ovarian tumors like pain, bloating, to rule out your cervical cancer. It's important to ask about smears, any foul smelling discharge, any postcoital bleeding. Those are the questions which are important. And also HRT, herbals, smoker history, and BMI. Those are the important questions. And extended part of your information gathering, which is an examination, where you need to tell her that you want to examine in the presence of a chaperone, even to look at the neck of the womb, because you are not just assuming it's an endometrial polyp and not ruling out cancers which are arising from the cervix. Okay, so those are the questions which are very, very important in your information gathering. As far as the applied clinical knowledge is concerned, the way you explain the causes of the postmenopausal bleeding, the chances of this could be a cancer, and then involving the MDT, and how we are going to go ahead depending upon the histopathology report, whether you just follow her up or do the reassurance and send her home based on the polyp results, or you would offer her further treatment. So all that will be a part of your applied clinical knowledge. A very important station, it is not just the postmenopausal bleeding with an endometrial polyp. She has got a multiple risk factors, and we need to address that as a whole. So that is something which is extremely important in this task. I hope you would practice this and get this right if it turns out to be your exam station. All right, all the very best, dear.